Okay. That's a correct answer. That is A. Let's see another question. Of course, before I go to the next one, it is expected that the thenar muscles will be atrophied in case of carpal tunnel syndrome. Isn't that right? In case of carpal tunnel syndrome, all three thenar muscles are going to undergo atrophy, right? Yeah, right. Also, the sensory distribution in the hand that is responsible for the median nerve, will also be affected. But there is a certain area that is spared sensory distribution, sensory function of the median nerve in the hand. So my question is, which part in the palm of the hand that will have intact sensation in carpal tunnel syndrome that is within the distribution of the median nerve? Yeah, any idea? Yeah, that's correct. Palmar surface, because suppose that this is, if you can see the screen clearly, suppose that's thumb, right? I'm bad at drawing, but right, index, middle, ring, little finger, and so on. That's the area of the carpal tunnel, right? Carpal tunnel contain how many tendons passes in the carpal tunnel, by the way? How many tendons pass within the carpal tunnel? Yeah, there are 9 tendons that pass. There are 4 tendons of the flexor digitorum profundus and 4 tendons of the flexor digitorum superficialis, and 1 tendon for the flexor pollicis longus, and 1 nerve, which is the median nerve. The median nerve, as it approaches, as you can see on the screen, yeah, it approaches the carpal tunnel. Just before it does so, it gives a palmar branch, which is a sensory branch. So it enters the carpal tunnel, but before it will give a palmar branch. Palmar branch passes not within the carpal tunnel, but it passes superficial to the flexor retinaculum and supplies the base of the palm, you can say, this area of the palm. So in carpal tunnel syndrome, this is spared. That can be a common question in the exam, by the way. Right? So let's see the second question. Yeah, this this question, which is following a fall from height, right? A 19-year-old male patient presents with mild clawing of 4th and 5th fingers. Mild clawing. This addresses the knowledge for the ulnar paradox, right? Which is closer to the paw, the more the claw. It means what? It means that proximal lesions of the ulnar nerve are going to be manifested with severe clawing, whereas distal lesions will manifest with severe clawing. Proximal lesions will manifest with mild clawing. Is that right? Yeah. Ulnar nerve paradox. Also, I've seen a question about the mechanism of clawing in ulnar nerve, in the proximal ulnar nerve injuries. Why clawing is there? Does anyone have an idea why it happens? So Dr. Muhammad said, if said severe clawing equals ulnar nerve at the rest. Yeah, severe clawing, ulnar nerve at the rest. Very excellent, Dr. Bilqais. That's a very excellent point. Why there is clawing? Because, the intrinsic hand muscles, they act on a structure which is called the dorsal hoods. Dorsal hoods, or the extensor hoods. also called extensor hoods. This thing is, we don't need to know the exact anatomy of these. They are very complex structures. We don't need to know that for the purpose of the exam. But what we need to know is the function, like why, how do they work? When they work on the extensor hood, they do mainly two things. Number one, flexion of metacarpophalangeal joints, right? MCP joint, flexion of the MCP joint, and extension of interphalangeal joints, right? IP joints, all of them, both proximal and distal interphalangeal joints. You can say this is like upstroking movement, right? Now, when there is paralysis of the intrinsic hand muscles, the extensors, which are intact, they are supplied by the radial nerve or branches thereof, right? They will work and cause extension, the opposite of this movement, which is instead of flexion of the MCP joint, there's going to be extension of this joint. And instead of extension of the IP joints, interphalangeal joints, the flexors, the long flexors, which are intact, are going to cause flexion of these joints. So you end up with a claw, right? You get that idea? You are going to end up with a claw. So that's the mechanism of how clawing occurs. For example, if I ask you another question, in case of distal ulnar nerve injuries, that is at the wrist, right? Ulnar nerve injury at the wrist. Why clawing is severe? Why is that? Because that is against logic, right? Because if it's proximal lesion, it's a proximal, it should be severe claw, but actually the opposite. So it is kind of weird. I mean, why it happens? Yeah, that's correct, which is the FTP, flexor digitorum profundus, the ulnar half of this muscle. That is going to be intact. Very excellent. Yeah. Let's move to another question. So regarding the brachial artery, which of the following anatomical relationships is correct? Asking about the anatomical relationship of the brachial artery. Yeah, it's a very simple question, right? Tan, you can remember this relationship as tan, which means from lateral to medial. Tan from lateral to medial, which is, that's Dr. Muhammad came up with another mnemonic, MBBR. Can you please, tell us more about that? MBBR. MBBR stands for yeah, median nerve. Oh, that's from medial to lateral, right? That's from medial to lateral. Tan is from lateral to medial. Both will work, right? T stands for the tendon of the biceps brachii. A stands for the artery, which is the brachial artery. And N stands for the nerve, which is the median nerve, right? Median nerve is the most medial structure within the antecubital fossa. Yeah, that's nice. Okay, so that's nice. So the tendon of the biceps brachii, where does it insert? It is within the antecubital fossa. And then what's going to happen to that? I mean, the site of insertion. That's my question. Yes, that's correct, Dr. Pooja. It is predominantly in the radial tuberosity, right? The brachialis muscle inserts in two locations. Can anybody tell me these two sites where the brachialis inserts? Yeah, number one, it inserts in the ulnar tuberosity. And number 2, it inserts in the anterior aspect of the capsule of the elbow joint. Magnificent, very great. Okay. So that was a third question. Let's move to another question. Yeah, very famous question, this one. It comes in almost every exam. The carpal metacarpal joint of the thumb. That is what type of joint? The carpal metacarpal joint of the thumb, which is what? Which is the first carpal metacarpal joint. That is a saddle joint. It is a saddle joint, right? So if I tell you, so it's option D. If I tell you a type of joint, and then you guys tell me what type is it, right? It is considered which type of joint. For example, if I tell you the interphalangeal joints, interphalangeal joints, these are what type of joints? Interphalangeal joint. No, interphalangeal joint is an ellipsoid joint. It's an ellipsoid joint. If I tell you, for example, the glenohumeral joint, glenohumeral joint, that's what kind of joint? Glenohumeral joint. That is, it's a ball and socket joint. Yeah. If I tell you the knee joints, the knee joint, what kind of joint is that? Yeah, some people consider the knee joint as a modified hinge joint, right? According to Gray's Anatomy, that is considered as a bicondylar joint, right? Or you can say a modified hinge joint because it's not totally hinge. For example, if I tell you a joint which is strictly a hinge joint, that is what kind of joint which can be considered as, yeah, the elbow, which is the joint between the humerus, the trochlea of the humerus, and the ulna, right? Humero-ulnar joint of the elbow joint, that is considered as a strict hinge joint. If I say the sternoclavicular joint, sternoclavicular joint, what kind of joint is that? Yeah, that's another example for a saddle joint. Correct. Fine. Let's see another question. Yeah, can anybody, for example, give me another example for a saddle joint? Another example. So we said the carpometacarpal joint of the thumb, I said sternoclavicular joint. What other joints could be considered saddle joint? So isn't there something else? Yeah, acromoclavicular joint is a plane. It's not a saddle joint. It's a plane joint. You have the incudum malleolar joint in the middle ear, between the incus, right, in the middle ear. And also you have the calcaneocuboid joint. Calcaneocuboid joint, that is between the calcaneum and the cuboid bone in the foot. These are considered saddle joints, right? Anyway, let's see another question. Yeah, 90-year-old female with osteoporosis presents with a history of a fall on the outstretched hand. Yeah, you're correct, guys. It's true lateral view, because that is the best view that is going to show displacement, and thus it's going to account for some injuries. For example, if I tell you, in case of distal radial fractures, if I tell you that EPL tendon rupture, it's a very famous condition, right? EPL tendon rupture, extensor pollicis longus tendon rupture. It's a relatively famous problem with distal radial fractures. This kind of problem is more likely if the fracture is displaced or if the fracture is undisplaced. Yeah? So is it more likely? Yeah, that's correct. If it is undisplaced fracture. Yeah. Yeah, it can be by mistake that sometimes the mic goes on or something, right? Okay. Yes, it is more likely with undisplaced fractures. Why? Why it's more likely with undisplaced fractures? Even in the exam scenarios, they will tell you, a female kind of having some problem, osteoporosis or anything like that, and then she falls. She has a problem when she places the palm of the hand flat on the table. She is unable to lift the thumb, right? And she is unable to extend her interphalangeal joint of the thumb. They will tell you, or they will say, when the proximal phalanx of the thumb is stabilized, the patient is unable to move the distal phalanx into extension. And then they will tell you, on imaging, there is undisplaced fracture in the distal radius. Yeah, so Dr. Pooja correctly said, because the EPL is contained in it, in undisplaced fracture. If displaced, it will get released. That's a very nice, simple answer. You know, the extensor retinaculum, so that's the distal radius, right? And here are the long tendons of that. Here's the long tendons, like the EPL tendon here, right? And then overlying it or wrapping it is the extensor retinaculum, right? Extensor retinaculum is here. If there is a fracture which is undisplaced, or let me tell you the other scenario, if there is a fracture which is displaced, if there's a fracture which is displaced, this extensor retinaculum is going to rupture away. So it will look like this, right? So here's the fracture site. Suppose it's a displaced fracture. The extensor retinaculum will be disrupted, and the long tendon will be able to escape the fracture site. It will usually survive this injury. But if there is a fracture site where there is a fracture hematoma that is being formed, the tendon is held against the fracture site, and it will absorb almost all of the trauma. It will not be able to escape the fracture site. So EPL tendon rupture will be more likely with undisplaced fractures of the distal radius, as opposed to displaced ones. Okay, let's move to the next one. Yeah, so a 60-year-old female sustains an undisplaced, again, well, we were just talking about this question, right? Undisplaced distal radius fracture following a fall on the outstretched hand. The fracture was fixed in a splint. 4 weeks later, she presents to the clinic. She is unable to lift the thumb when the hand is placed flat on the table, meaning palm down, it is on the table. So if you lift the thumb in this movement, what kind of movement? What is this movement? If you lift the thumb while the palm of the hand is flat on table, this is considered what? This is considered extension movement. That's extension. Abduction can occur in two ways. Abduction can occur in two ways. One way is that it's very simple, right? When the hand is placed flat like this, but dorsum down, Okay, guys, dorsum down. So suppose that is the hand, but it is like this, dorsum down, and you are seeing the front of the hand, the palm, right? And the thumb is moved like this. That's one way of abduction. Another way of abduction is actually making the thumb perpendicular to the palm. That's another way of abduction, right? These are done by different muscles. Anyway, so yes, the answer here should be EPL rupture. That is A, extensor pollicis longus tendon rupture. Right? Yeah. Let's see another question. Also, this one, very famous. I really advise that everyone, whether they are with me on the course or elsewhere, to really focus on scaphoid fractures and the anatomy of the scaphoid. Could really help in the exam. Really helpful. So they are asking, majority of people would have answered proximal pole, but the correct answer should be waist. The waist of scaphoid is the one that is most commonly fractured. It is the weakest area in the bone. Right? Which artery supplies the scaphoid bone? What artery supplies it? Yeah, the radial artery through a dorsal carpal branch. Dorsal carpal branch of radial artery supplies the bone. This artery enters the bone from its dorsal surface distally, from its distal pole dorsally. You get me? And then it moves proximally, and you know the story, right? Okay. Let's see another question. Yeah, that's correct, Dr. Muhammad, I think. That's correct. It moves retrogradely, right? Okay. So let's see another question. What is die punch fracture? What is die punch fracture? Right? Die punch fracture is a fracture of distal radius. It's an impaction fracture, and it is considered an intra-articular fracture that involves the lunate facet of the radius. Right? It occurs due to axial loading on the lunate. You know that the distal radius is like this, right? Let me show you. So the wrist joint, what is the wrist joint? I mean, what forms the wrist joint? It's an articulation between what and what? Scaphoid and radius. Radius and carpal. No, I mean, yeah, the carpal. But I mean, like this is the distal radius, right? Here's the distal radius. And that's the radial styloid. And here's the distal ulna. And this is the ulnar styloid. Right? Right? Now, that's the scaphoid. And here's the lunate. And then the, tracheum, whatever, pisiform. Right? And I mean, what kind of articulation? What is happening here? Of course, it is the distal radius, the scaphoid, and the lunate. Then the ulna does not participate in the wrist joint, actually. The ulna is separate from the wrist joint by the triangular cartilage. There's an articular disc here, right? It's a fibrocartilage. It separates the ulna from the wrist joint, so it doesn't articulate. So actually, the wrist joint, you can say, it's an articulation between the distal radius and the scaphoid and the lunate. Die punch fracture occurs when there's axial loading on the lunate like this. This fractures the articular facet of the distal radius. It may fracture the lunate also, right? But usually the classical description of this die punch fracture is a fracture of distal radius only. That is the classical description. When there is AVN of the lunate, that's called what? The name of the disease. It's also very famous in exams. When there is AVN of the lunate. Yes, Kienbock's disease. When there's AVN of the scaphoid that is called AVN affecting the scaphoid. That is, yeah, what thing? AVN of scaphoid. That is called Prizer's disease, right? That's called, I hope I'm writing it correctly, Prizer's disease, right? Prizer's disease is the AVN, idiopathic avascular necrosis of scaphoid bone, right? Let's see another question. Right, following a road traffic accident, patient is suspected of suffering from lunate dislocation. What view would you want? The most important one. Lunate dislocation. So when the lunate dislocates, let me show you. Perilunate or lunate dislocation, relatively uncommon thing, but it usually needs some kind of high energy trauma. So suppose this is representative of the carpal tunnel, right, as you are seeing, and this is representative of the flexor retinaculum, right? Lunate is somewhere here. Suppose that's lunate. When lunate dislocates, it's usually volar dislocation. Volar means anterior dislocation, like this, right? And if the lunate dislocates like that, right? So suppose the lunate has dislocated volarly like this. Now, of course, it's going to cause what? So what if there's volar dislocation? What's the problem? What's going to happen? Yeah, acute carpal tunnel syndrome. Acute carpal tunnel syndrome, because it's going to increase the pressure in the carpal tunnel. Very acutely, it's going to increase the pressure here. So the best view to see if there's volar dislocation or not, that's going to be what kind of view? Lateral view, right? Lateral view, like X-ray machine here, the beam, so you can see if it is dislocated anteriorly or not. Right. Yeah, that's almost always asked about, like the borders of the quadrangular space, the borders of the triangular space, and also the borders of the triceps hiatus, or that is the triangular interval. They are all very important. So the borders of the quadrangular space, you have superiorly teres minor, inferiorly teres major, medially long head of triceps, laterally surgical neck of humerus. If I ask you borders of triangular interval, or otherwise known as the triceps hiatus, what are the borders of that? So I hope I can draw this correctly. Okay, so that is, suppose that's the glenoid cavity. That is the lateral border of the scapula. That is the medial border of the scapula. That's the superior border. That's the suprascapular notch. And you know, that is the, what is that? Coracoid process. And here's the spine of the scapula, suppose. Okay. And that is the, what is this? Humerus, right? Okay, so that's supraspinatus. Supraspinatus. Supraspinatus, what's the insertion site for the supraspinatus? Yeah, comes and attaches where? That's the tendon. It will enter into the subacromial space and inserts at the superior facet of the greater tubercle, right? Superior facet of the greater tubercle of the humerus. And then that's in the supraspinous fossa. In the infraspinous fossa, you've got this muscle, which is infraspinatus. Is it clear? Can you understand this diagram? Right? This diagram is clear. Okay, so that is the infraspinatus. Infraspinatus attaches in the where? Insertion. In the middle facet of the greater tubercle, middle facet, right? And then you have, you know, just near the lateral border here, that's the origin of another muscle, which is teres minor. Teres minor inserts where? It inserts lower facet of greater tubercle of the humerus. Yeah, so something like that. So they are all, like, for example, also a famous question. Of course, you must know all of the rotator cuff muscles. Also, you must know the action, the innervation, everything about them is important. Then you have this muscle, which originates near the inferior angle of the scapula and inserts on the medial lip of the intertubercular sulcus. That is teres major, right? Teres major. Nerve supply for supraspinatus. Suprascapular nerve. Also infraspinatus, right? Also infraspinatus. Nerve supply for teres minor. Axillary, yeah. Nerve supply for teres major. Nerve supply for teres major, that is what? Lower subscapular nerve. Lower subscapular nerve, which is a branch of the posterior cord of the brachial plexus, lower subscapular nerve. And then you have a friend here, which comes here. That's the long head of the triceps brachii. Long head of the triceps brachii. So then you've got that's quadrangular space here, right? This is triangular space, and that is, what is this? Triangular interval. This is called, the triangular interval is not in the, it's not in the posterior wall of the axilla, right? You can say it's a window between the anterior and posterior compartments of the arm. But because the axilla, strictly anatomically speaking, the inferior limit of the axilla posteriorly is the lower limit of the teres major, here, right? So the triangular interval is bordered laterally by the shaft of humerus, medially by the long head of triceps, and superiorly by the lower border of teres major. What are the structures passing through this triangular interval, or also known as triceps hiatus? Yeah, radial nerve, that's correct, and radial nerve, and also what else? Yeah, deep artery of the arm, or profunda brachii artery. Both pass through this space. This is triangular space. Triangular space superiorly, that is teres minor. Inferiorly, teres major. Laterally, long head of triceps. The circumflex scapular artery passes here. And of course, the quadrangular space, you have axillary nerve and posterior circumflex humeral artery and posterior circumflex humeral vein. They pass through this space, right? Okay. Let's see another question. Okay. Okay. Following a blow on the forearm with a baseball bat, a patient presents with weakness of thumb flexion and numbness over the thumb and index. Which, very simple, right? Question. No problem with this question. Yeah, median nerve. Median nerve. Let's see another question. Following a road traffic accident, a patient presents with loss of sensation at the lateral forearm with inability to extend the elbow. Okay, so I always advise when you face some kind of question which is kind of boggling and confusing in the exam, you know, in the exam they give you this little board, whiteboard, or a little sheet that you can work on, right? You can just write what you found in the case, right? So what is in the case? Following a road traffic accident, so that's a trauma case. He presents with two things mainly. Number one, loss of sensation on the lateral forearm, right? Loss of sensation on lateral forearm. That is what? Yeah, what's that? What's the function of that? Yes, Dr. Bilqais. That is musculocutaneous nerve, which is lateral cord. So there's a problem here, musculocutaneous lateral cord. You write like this in the exam, okay? Number two, what is the other problem he has? Extension of elbow. Elbow extension. Elbow extension, that is what thing? Yeah, so in the exam, write elbow extension, then write posterior cord, radial nerve, right? So let's see the options. That's the only two things they gave in the exam, right? So let's see the options. Injury to brachial plexus, maybe. Option B, axillary nerve. That's absolutely not on the table, right? Doesn't fit the injury pattern. Median nerve. Does not also explain elbow extension, loss of elbow extension, does not explain loss of sensation on the lateral forearm. So that's not the option. D, musculocutaneous nerve. Only partly explains, right? Only partly explains the loss of, you can say, sensation on the lateral forearm, but does not explain the loss of extension. And E, anterior interosseous nerve, doesn't explain anything. So the only thing that fits is a complex injury in the brachial plexus, right? So it should be option A, injury to the brachial plexus, right? Option A is the only one that explains these two findings in the case. So a lot of the questions are by exclusion. Like you only have to, you can't answer it like right away. You have to exclude all of the other options. Right. Let's see another question. Which of the following forms the lateral border of the quadrangular space? Again, lateral border of the quadrangular space is the surgical neck of the humerus. If there's a fracture in the surgical neck of the humerus, and there is another patient with a fracture in the anatomical neck of the humerus, which one is more likely to cause AVN? Which one is more likely to cause AVN? Yes, anatomical neck fractures. The anatomical neck fractures, the anatomical neck is thick. It is difficult to fracture, right? But if it fractures, the likelihood for AVN of the humeral head is more. The likelihood is more, right? if there is a patient that have supraspinatus tear, right? Supraspinatus tear. There is long-standing tear, chronic tear. Could be there any problem? Is there any problem that would occur in the joint over time, in the glenohumeral joint? Yes? Long-standing tear. Yes, very excellent, Dr. Pooja. Osteoarthritis. That is called, what is that? Rotator cuff arthropathy. Rotator cuff, that's called rotator cuff arthropathy. Why it occurs? Because, very simple. Look, you know, supraspinatus resists superior translation of the humerus. Let me show you. Let me show you. So, supraspinatus tear, so this is the glenoid cavity, right? And humerus, scapula. That's the humerus, right? This is supraspinatus muscle. Supraspinatus muscle tendon is inserting on the superior facet of the humerus, and it resists superior translation of the muscle by another, of the bone by another muscle, which is what? Deltoid. The deltoid muscle is here, right? It inserts on the lateral aspect about mid-shaft humerus at an area called V-shaped roughening in the bone here called deltoid tuberosity. And the deltoid muscle, it has with its toe this constant superior pole of the humerus. This is normally resisted by the supraspinatus. Now, should there be a tear in the supraspinatus here? Look carefully. If there's a tear here in the supraspinatus, what's going to happen? There is superior translation of the humerus. Because the supraspinatus is no longer there, the superior translation of the humerus can no longer be resisted by the upward pull of the deltoid muscle. So the joint, because there's superior translation of the humerus, the joint is no longer congruent, is no longer smoothly applied. The humeral head is no longer smoothly applied against the glenoid cavity. So the mechanics of the joint are altered. Over time, abrasions occur in the joint surface, and finally, osteoarthritis. Osteoarthritis. This condition is called rotator cuff arthropathy. All right, right? So what is the treatment for this? The definitive treatment for rotator cuff arthropathy. Yeah, joint needs to be replaced, all right? The joint needs to be replaced. But what kind of replacement? What kind of replacement? Yeah, reverse arthroplasty. Reverse arthroplasty. Right? We've talked many times how or why reverse arthroplasty needs to be there. What is meant by reverse arthroplasty? The meaning is that normally the glenoid cavity is the cup and the head of the humerus is the ball, right? In case of, if you want to do this thing, the glenoid cavity is the ball and the humerus will be the cup. What is the benefit of this? The benefit of this is that the humerus is pulled laterally. So what? So that the deltoid is stretched. Deltoid becomes more stretched and it will act on a longer fulcrum. So that deltoid can now initiate shoulder abduction. You get that idea? Right? So that's why reverse arthroplasty is better in case of rotator cuff arthropathy, right? So let's have we still have many questions. Let's have a break, okay, for about 10 minutes or 15 minutes for prayers, and then we will continue. Thank you, guys.